Thank you.
Thank you. Questions from the committee, Mr. Bonta.
Thank you. I had a couple of comments and also some questions that I want to raise. Appreciate all the presentations. Thank you for the public comment. With respect to the additional positions that have been requested, my understanding is that the estimates are still that it'll take about 4 years to clear the current pending investigation workload. And so I guess my question is, it seems like a significant amount of resources that are being provided, but 4 years seems like too long. What do you need to do something in a shorter time frame than 4 years? And then I also raised similar questions that have already been raised and echo them about the 64 positions that are limited to only 2 years with a 1 year train up period, and then essentially you get 1 year of actual work post training from them. And is that the wisest use of resources? So that's my first question. And then also want to hear a little bit about the prioritizing of investigations. My understanding is that in LA County, the investigations that are being prioritized and completed are those involving immediate jeopardy. So Tier 1 and 2 on the nursing home side. I'd like to know more about how the prioritizing is working on the hospital side. And I understand that level 3 on the hospital side is actual patient harm that is not immediate jeopardy. So are those being prioritized or not? And what does that include? Could it include sexual assaults? So just kind of want to figure out what's not being prioritized so we can be real clear about that. And then finally, I went back and I looked at Health and Safety Code section 1279.2, which says that an investigation is opened up in, I think it's 2 days, 48 hours, and then an investigation must be complete in 45 days. So what do we mean by complete? Does that mean that the investigation is concluded and a corrective action is put in place and penalties are assessed, or not? Because I'm getting some anecdotal stories that are being shared with me that some investigations are an incident's occurring at one point in time, and then 3 years later, the fines are being levied, and so you have staff turnover. You have maybe some of the relevant documents aren't so readily accessible. Maybe memories fade, and for institutions that have made a mistake and are willing to accept responsibility and want to pay the fine and face the consequences and move on, how do we allow them to do that? So and I want to make sure we're also talking about the hospital side here. So that's a lot, but
Okay.
Please feel free to respond.
I'll start, and I'll turn some of your questions over to my colleague, and then remind us if we missed some of your pieces. So in regard to how long it will take to clear the open pending cases, as has been stated before, it takes us at least 12 months to get a surveyor fully trained and able to, and passing, which includes federal training, to be able to be fully functional in the field. And so that time lag, that training time lag, is something that we can't overcome. So we couldn't just, by staffing up to any level tomorrow, we would still face that training barrier. And then, as I mentioned before in my testimony, with regard to the limited term positions, as we hire people into those limited term positions and we get them fully trained, then we will be rotating the trained staff into permanent positions as they become vacant, so we don't lose their expertise. And then each year, as we update our estimate with our workload and resource estimates, we can revisit the staffing levels. But the staffing levels that we've proposed are, as I said, the limited term positions, we would be transitioning into permanent positions as they become vacant. I'm going to ask my colleague Scott Vivona to address how complaints are prioritized.
Sure. So part of your question was, how does Los Angeles County prioritize their complaints, and how do they do their workload? As with anything else, and you've heard from the public testimony that LA County has staff challenges and resource challenges. So we have been working with Los Angeles County this last several months or so to help them with prioritization of the workload. much like anything else in the world, it does become a balancing act of priorities, and so those priorities may change from day to day, from hour to hour, depending on the severity of whatever else is before you. So we've been trying to work with Los Angeles County to help them prioritize the highest priority workload so that they can get out there to do their work, so that people who have an urgent need for an investigation or facilities that have an urgent issue going on will receive a more prompt response. And so that is just part of our day-to-day work that the program engages in all of our programs. When it comes to hospital complaint prioritizations, I do want to reassure the committee that every complaint that comes in receives the same level of triaging that any other complaint would be. So that's first and foremost. We intake the information from the respondent, the complainant, or the facility. It is reviewed by our nurse surveyors and our nurse managers for appropriate triage and prioritization. And then again, depending on the workload availability of staff, we'll determine how quickly we can roll out. In some cases, if we don't have available nurses, supervisors and or managers will roll out on priority 1 complaints, and that's not an uncommon factor in our world. So we are triaging the most appropriate and highest priority complaints and addressing them within our time construct, either from the statutes that are before us for the immediate jeopardy investigations, both in hospital as well as in long-term care complaints. Again, on the 45-day mention that you had in the statute, again, that is a measure that is something that is an issue for the department. We are trying to prioritize and complete those investigations timely, but as you mentioned, in some cases, we're not able to complete them on time. That has resulted in a delay in terms of completion of the investigation. And for the hospital settings, if it's an immediate jeopardy type of a situation that warrants an administrative penalty, which I think is kind of what you were referring to, those issues have been in the past worked on as priorities allow, but some of those cases have taken some measure of time to complete. We have been raising this up as a conscious decision point in our program to make those determinations a higher priority, to complete those more timely so that the hospital can get the results of their investigation timely so that the public knows that we've been out there to address the issues. And if a penalty has been warranted based on the investigation, that there is a more timely issuance of that administrative penalty so the hospital can address those care concerns and or pay the fines or challenge the department based on the investigation that we're issuing.
I would add that when we're exiting the facility, we do give them notice of an intent to cite. And then the delay, so they know when, and they have to immediately issue a plan of correction to fix the deficiency that the citation would be based on. The delay then comes in actually issuing the administrative penalty, and some of the factors that go into that delay are the fact that there are significant levels of supervisory and legal review of those issues before the penalties are actually issued. But we acknowledge that there is significant delay in issuing our penalties, and it is an issue that we're working hard to address.
So I appreciate your comments. I mean, to me, it couldn't really be more clear that there's really important investigations on really important issues that aren't happening fast enough. And I mean, and that's what we're here to fix. Do we think the proposal is going to fix that? I mean, if we come back here in the same hearing next year, are we going to be able to say that there's significant improvement being made and we're hitting the time frames required by law and hitting those benchmarks? Or do you continue to have concerns about this proposal not being able to provide the resources and support that needs that will allow you to get to where we need to be in this state on these investigations?
It is certainly our intention that we would appear before you here next year showing improved performance on timeliness and completion of investigations. It won't all happen. There won't be 100% timeliness and compliance in 1 year, as our proposal has stated, but we would expect, it's certainly our expectation of ourselves, that we would have demonstrated improvement by the time if we were back here before you next year.
Just as an add-on to Mr. Bonta's question, would you provide a year-to-year report about how you're doing? Because it seems to me we want to give you the resources that you need to do the job. As someone stated, I think we want to also tie some metrics to that so that we can tell the story.
Right.
Really? We're not here to jam anybody up. But we need to be able to tell the story that somebody is better off as a result of the resource additions. Would you be able to provide us that year-to-year report that shows you provided us the resources? It's really saying performance. Here's our performance. Here's where we've improved. Here's where we need to get better. Can you provide that for us?
Yes, and in fact, I would say we're already doing that with the skilled nursing facilities, posting our quarterly reports, and we show going back to fiscal year 2011-12. How the number of complaints that remain open, and we're already demonstrating progress there just by things that, and also our timeliness to complete investigations. So we are already posting those metrics, and yes, in a year we can tell you more of that story.
And we will be updating this with some hospital reporting, so that will be coming in the next coming months, so that we'll have it for the long-term care as well as the non-long-term care side of the house.
What is hospital reporting?
Pardon me?
Right now we're just reporting metrics for long-term care facilities, and he was saying we're moving towards reporting the same type of metrics for hospitals.
Got it. I'm sorry. I thought you said hostile reporting.
I'm sorry. No, hospital.
We're not going to be hostile, but we do want the information.
No hostility.
Got it. Back to you, Mr. Bonta. Anything else?
Just one thing I wanted to clarify. I mean, I understand the 4-year period of time that's been explained and the ramp up that's necessary. But my understanding, please correct me if I'm wrong, is that's how long it takes to complete the current pending investigation workload while also keeping up with the new workload. So when you say the latter, when you say the new workload, my understanding, correct me if I'm wrong, is that the new workload is being addressed in a timely fashion.
That is
so you're meeting all time frames and time benchmarks appropriately. So
that is the goal.
Being faster than what you are now.
Yes, I mean it is the goal that we would be more timely. So, for example, we currently, the metrics that we're posting show our number of complaints completed by less than or equal to 90 days, 91 to 180 days, 181 to 365 days, and greater than 365 days. So yes, of course, we would expect that those numbers, the percentage of complaints that are in that greater than 365 day to continue to decline, and for the number that are in the less than or equal to 90 days to go up. Yes.
Couple questions for Mr. Chu.
May I have one more just to finish up?
Could we have Mr. Chu get one in? He's got a meeting, and we'd like to get his in. He'll be next.
My apologies. I was actually going to defer to Mr. Bont on that. But I know that there have been some suggestions that investigations be completed for the most serious types of cases. So deaths within investigations within 90 days, serious bodily injury within 120 days. Do you have any objection to those sorts of standards, or is there a way for you to prioritize the most serious cases to make sure that they are investigated within a certain period of time?
We are aware of the trailer bill language proposal, and we have it under consideration, but we absolutely do prioritize our workload. Any complaint that comes in currently, we prioritize them as immediate jeopardy, where there's evidence of, or non-immediate jeopardy high, and we already have timeframes for initiation of that. So I can't comment right now on the specific proposal, but we do have that under review.
I think from my perspective, I am one who definitely supports the increase that we're talking about. I think the question we all have is how much will that money buy us as far as being able to clear off the backlog and having some real understanding of if we were to invest this money, I think we all expect the numbers to get better.
Absolutely.
But how much will they get better? Really understanding those metrics. If we get a certain amount of money, do we expect numbers to go from X to Y? And really understanding that, I think, will help us evaluate whether this proposal makes sense.
Yes. Thank you.
Mr. Bonta.
So just in follow-up to the prior dialogue we just had, I raised an example of a hospital that had an incident occur on one period of time, and then 3 years later we had the fine being levied, and then kind of the problems that causes with lack of certainty and fading memories and documents that may not be readily available. With the new resources and the new commitment for regarding faster response to new cases, is that something that we can expect would not occur in the future? The 3-year delay?
We would certainly include issuing citations as part of our workload that we intend to improve on with the new resources.
Thank you.
Thank you. So you've heard the committee loud and clear. We want to support the resource allocation. We're also placing an expectation for increased time around completion of reports, especially those most severe. We'd like you to adopt the recommendation from the LAO's office for 90 days for incidents involving death, 120 days for those involving serious bodily injury. Is that something that you're prepared to do?
I don't believe that's the LAO.
Sean Martin with the legislative analyst. That wasn't our.
I think
strike
it's
that part.
It's trailer bill language from the
Is that
Disability
something
Rights
that you're
Committee.
willing to take up voluntarily?
We have it under consideration. I cannot give you an answer here today, sir, about that
We'll look
particular
forward to your
timeframe.
response to that. I had some separate questions. Many of the folks who spoke in public comment talked about lack of reporting as it relates to lack of enforcement around ratios. I want to give you an opportunity to speak to that directly. It's a big interest, but I'd like to give you an opportunity to speak to that directly.
Sure. So we need to separate. I believe most of the public comment was directed at staffing ratios in hospitals. And we do only assess compliance with hospital staffing ratios when it is a matter of complaint. But when we do receive that complaint, we do go out and investigate whether ratios were being complied with.
I'm not sure if I understood.
So we are not routinely in hospitals just assessing, taking a look at their staffing ratios over time, which is something that we do in skilled nursing facilities, looking at the minimum hours, because that's part of a program with Department of Healthcare Services.
Got it. So only when there's a complaint.
Only when there's a complaint.
Got it. And has there been any backlog in being able to investigate complaints regarding ratios, staffing ratio?
I don't have that data available to know what kind of complaints may be lagging in that regard, so I don't have that information available.
Got it. And you did talk about, you had a number of stakeholder conversations. Thank you for that. I did understand, does that include, nurses and other staff who work directly with the patients who see things that might be useful to strengthening the reporting process?
The nurses have been in attendance at our 3 all-stakeholder meetings, and we have actually met with them separately after those meetings, and we have discussed with them. We have many things to do in the future regarding implementing the Hubbard report, and those will include involving field staff who do the work. For example, when we're looking at a quality improvement process for a particular activity, and there will be nurses who are members of our staff but who do the field work will be involved in those activities.
And there was something about how fines and fees get assessed, and it struck me, the comment was to the effect that there aren't any, and that struck me as odd. It would seem to me that if there are bad actors, that you, as much as anyone else, would want them to be identified, that there would be financial consequences for that, and that those dollars could in turn pay for enforcement, could pay for work that will result in better care for patients. What is the status of that work?
So the comment that, as I heard it, was that there had never been a fine issued for failure to meet the nurse-patient ratios in a hospital setting. And I don't know, I can't speak to whether, in fact, that is the case. But we do issue citations and fines for a variety of deficiencies.
And I can add to that. So the statute does not allow us to issue a monetary fine for nurse staffing ratios in hospitals. We have to meet the standards in statute for an administrative penalty, which, if the staffing was a component to an incident that occurred where actual harm was attributed, it would be rolled into that investigation, but we don't have the statutory authority to issue fines for ratios.
Got it. Is the issue then, do you find situations where facilities are in compliance with ratio requirements, and so it's not necessarily a compliance, but it's what's in the regulation?
The investigations, what I'll say is that when we go out to investigate, if the unit or the hospital is below the ratios, we will issue deficiencies to the hospital, and they must give us a plan of correction on how they're going to address that under ratio.
Got it. It's an important topic, as you can imagine, one that we all care deeply about. I anticipate it'll be one that we'd like you to come back and revisit with us in more depth the conversation of ratios as it impacts care. We want to hear more about how your staffing up is going and how that is allowing you to do what you need to do to have the resources to get the job done. I'll say this, I also want to hear what your challenges are, too. We don't expect you to come here and get beat up.
Right.
We will hold you accountable if we think that there are things that need to be done better. Okay. But on the same token, we want to hear from you, what is it going to take to get the job done? We want to have that kind of level of candor and commitment to providing the best quality care of those who are very vulnerable and who depend on all those folks that we heard from today.
Okay. Thank you, Mr. Chair.
Thank you. But moving on to our next issue, and it is dealing with skilled nursing facilities and quality assurance fee. We'll hear from Ms. Cantwell, and there are representatives from Finance and the LAO's office. Should she speak on this one? Whenever you're ready, Ms. Cantwell.
Sure. Thanks so much. Mary Cantwell, Department of Healthcare Services. So just briefly, the governor's budget proposed a 5-year reauthorization of the rate methodology and provider tax for freestanding skilled nursing facilities. The proposal includes annual rate increases of 3.62% and continues the Quality and Accountability Supplemental Payment Program at existing levels of about $90 million per year. There were a couple questions that I thought I would address from the agenda in terms of whether currently Medi-Cal rates fully cover the cost of skilled nursing facilities. The answer to that question is no. It's about 93% of allowable costs are covered under today. And one of the goals of this proposal is to get these freestanding skilled nursing facilities to around what their allowable costs are at the end of the 5 years of the proposal. In terms of the general fund impact of this rate methodology, which we call 1629, even though there's probably been 6 or 7 versions of the bill at this point, certainly there have been general fund increases since the beginning of the rate methodology and provider fee, and that was known at the time that the original legislation was passed. Really, what 1629 as a rate methodology allowed was to begin a facility-specific rate method instead of an average median rate methodology for the facilities, and as well did institute this provider tax that has provided significant general fund offset over the years, but each year that there is a rate increase, the costs of that rate increase do get built into the base. But in the budget year, what we'll be seeing is if we did not have this provider tax, there would be a $500 million general fund cost. And then the other question I could address in terms of the evidence of the impact to quality of care since the creation of this methodology, one of the places that we look is the CMS Nursing Home Compare reporting that is done, and I think you heard a little bit about that in the previous panel. When we look at one of the more recent reports, which was a report on the 5 years of looking at the Nursing Home Compare website, we actually have seen a significant change in the quality metrics for California's freestanding nursing facilities. Currently, nearly 60% of California nursing homes are rated 4 or 5 stars. That's a 10 percentage points higher than the national average. And compared to 2009, a significant increase, as only 33% of our facilities were at 4 or 5 stars. Most of that is coming from a 20 percentage point increase in the number of nursing facilities receiving 5-star quality ratings, which is up from 12% in 2009 to 32% in 2013. So I'll stop there, see if there are questions.
No questions from the committee at this time. Is there any public comment? I'm sorry, anything from Finance? Anything from the LAO's office? We'll take public comment, 1 minute each, please.
Gary Passmore, Congress of California Seniors. I've got 3 things. The first is that our organization supports and continues to support the quality assurance fee and the 1629 reform and the 5-year proposal. We support the built-in 3.62% rate increase that's a part of that. And thirdly, we support the suggestion made earlier that the projection of a $600,000 surplus, if you will, in the fund from citations needs not to be added to a big state surplus. Instead, it needs to stay within the industry that raises it, and it ought to be used to fund the Ombudsman. Thanks.
Thank you.
Deborah Doctor, Disability Rights California. We opposed this bill in 2004 and have opposed every single renewal. It has not assured, the quality assurance fee has not assured quality. It has ensured an amazing increase in revenue for the nursing facilities. It's very fitting that we have this discussion now. We saw a parade of home and community-based services, which are alternatives to nursing homes, which have all gotten starved over the last 10 years while the state has been shoveling money at the nursing homes. Now, it's nice to hear finally an acknowledgement that the fee does not cover the costs. There is a huge general fund involved in these increases, which could be used to support the less expensive and more desirable services that people want in their own homes. We urge you, once again, to not approve an extension for a methodology which has not produced the results that it was promised to produce for the residents. Thank you.
Thank you.
I'm Charlene Harrington. I'm a professor at the University of California, San Francisco School of Nursing. And I've studied nursing home issues in California and staffing for about 30 years. And I'm speaking on behalf of myself and the California Advocates for Nursing Home Reform. We're opposed to this extension unless it includes an increase in minimum staffing to go with the increasing funds. Over the last 10 years, the AB 1629 was to give an incentive to nursing homes to increase staffing and wages. But they only got a very modest increase in staffing and wages in relationship to the large increase in the Medi-Cal funding. And I'm sorry, but I don't agree that the quality has increased in California. Most of the quality data is self-reported data, and CMS is trying to make efforts to make the reporting more accurate. The California has a 3.2 minimum staffing standard that it adopted in 1999 and is dangerously low. It's embarrassingly low, and it needs to be increased gradually over the next 5 years to get it up to the level that's recommended by the Centers for Medicare and Medicaid Services. And Cantor has submitted a detailed proposal to do that. Thank you.
Thank you.
Good afternoon. My name is Tippi Irwin. I'm the Director of Ombudsman Services in San Mateo County and also on the Board of Directors for California Association, what am I saying, the Long-Term Care Association for the Ombudsman. I want to talk about that 5-star nursing home assessment that they do, that you can look up and see where your nursing home stands, and that 60% of nursing homes in California rank 5 stars. It's a joke. We're in the facilities in San Mateo County. We make 6,000 visits a year, far more than licensing makes, way more than licensing makes. The 5-star rating is an absolute joke. I know that they're addressing it now, but particularly with relation to the 3.2 nursing hours. It's all self-reported and it's all a lie. So it's not working. It needs to be changed.
Thank you.
Jennifer Snyder on behalf of the California Association of Health Facilities, which represents the skilled nursing facilities throughout the state, over 800 in California. We support the governor's proposal, which provides a modest increase in the Medi-Cal rate for nursing facilities. Back in 2004, skilled nursing facilities throughout the state decided to make a commitment to provide and increase the Medi-Cal program through assessing themselves a provider tax. And that provider tax, as Mary talked about, provides an additional $500 million into the general fund, which is matched by the federal government, which gives the program $1 billion every year. To do that, that has actually allowed for the program to provide more funds into the skilled nursing facilities and into their rate. We believe that amount has actually increased quality. It's also increased staffing from 3.0 to 3.73% in the last 5 to 10 years. We've seen a 15% decrease in turnover, 36% increase in employee wages and benefits. We think that those monies have actually provided a better environment for patients, and we would love to continue to talk about staffing, but it should be outside that 3.62%. Thank you.
Thank you.
Karen Jones, Long-Term Care Ombudsman Services of San Luis Obispo County, also a board member with the State Ombudsman Association, CalCOA. I just want to say we strongly support any incentive that will help care facilities gain a higher level of care. I am very concerned, though, about some of the quality indicators and would urge the committee to take a look at some of them, which, although self-reported, some were already started as a high. The facilities were already achieving them, and they were quickly rewarded for those. And I'd also like to encourage the committee to continue to fund the Ombudsman program with these funds. The original intent was to increase the funding to the Ombudsman program over time. We'd like to see that continue. Thank you.
Thank you.
Michelle Cabrera with SEIU California. Good afternoon. On behalf of our 15,000 workers in nursing facilities, we believe that this proposal is just that. It's a proposal. It needs more work and refinement. We are concerned that there needs to be more transparency around the patient care ratios, which is why we've sponsored a policy bill on the topic, SB 779. The proposal to cap funding for the supplemental payments is also premature in our opinion. We have yet to see if it really drives the quality improvement that we believe it will. And the time is now to really add staff retention metrics to the formula as called out in law. The industry has made strides in their ability to track, but we believe that the department should be able to add it in as well. And we commend this staff recommendation to hold this open so we can continue to work on this issue. Thank you.
Thank you.